Hello, my name is Joanna Ng-Glazier, and I'm representing the University of Pittsburgh Department of Plastic Surgery. Thank you for allowing us to present our work today. Simulation is an effective mode of virtual surgical training, but its role in plastic surgery is not well defined. We therefore sought to create a formal simulation curriculum in our program and to understand its current role in our education model. We distributed a survey to all residents to identify areas of perceived clinical deficiency. Based on the results, we created a multi-session curriculum using models of our own design and supplemented by electronic resources, landmark articles, and expert faculty oversight. A survey-based outcomes assessment was then performed before and after each session to measure the following: improvement in knowledge and skill comfort, quality of models, overall satisfaction and perceived value, and 12-month retention data. 24 residents participated and identified the following: preoperative breast markings, ultrasound for various procedures, and percutaneous pinning maneuvers. These sessions were then held last academic year and repeated this year, noting that the last session didn't occur secondary to coronavirus restrictions. These models were then designed specifically to target skill practice as opposed to memorization of a procedure. We injected viscous lidocaine into chicken breasts in order to identify and aspirate abscesses. We used a pork buttock and its fascial planes to practice tap blocks. We then used intact and ruptured implants in simulated subglandular and submuscular environments to look at periprosthetic seromas and to aspirate them. We used saline-filled linear balloons to practice ultrasound-guided intravenous access, and used our own anatomy to look at tendon and carpal tunnel pathology, as well as identify key areas for upper extremity nerve blocks. A breastosis model was created using saran wrap implants and surgical bras, on which residents could repeatedly practice wise and vertical patterns, latissimus, free flap, and transgender massive weight loss modifications. Lastly, a chicken hind quarter was used without C-arm in order to practice percutaneous pinning maneuvers, which, when deboned, could assess for operator accuracy. On a Likert scale of 1 to 10, we found that comfort and skill level doubled for all of our sessions. At 12 months, breast retention for markings was about 50% and was perceived as somewhat helpful, with higher baseline comfort levels in the year prior and a 20% increase in skill level after this session. For ultrasound, retention was about 50% and was perceived as very helpful, with higher baseline comfort values than the year prior and a 50% increase in skill knowledge after this session. Average satisfaction ratings were 86 to 92% and similar the year after. And when stratified by training level, we found that certain sessions had greater impact for junior compared to senior residents and integrated compared to independent residents. In conclusion, we created a formal simulation curriculum and found that our models were effective in improving skill, comfort, and knowledge level after each session. We found that repetition was important for retention. Moving forward, we'd like to perform more long-term validation studies and, importantly, clinically correlate them with a resident's progression throughout the program. And as we found during coronavirus, these sessions, whether virtual or in person, can be helpful for supplementing clinically deficient times. I'd like to thank everybody in the department for their help with this study and welcome any questions you may have. Thank you.